Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. Welcome to our webinar today, Building Malaysia's Capacity to Treat Cancer for the Next 5 Years. My name is Azrul Mabkalib from the Galen Centre for Health and Social Policy. This is a series of webinars where we discuss the various policies and actions implemented during this period of crisis, which have impacted the management, control, and treatment of cancer. This series is powered by the Pharmaceutical Association of Malaysia. It has been a long couple of months since the imposition of the Movement Control Order in March, which became the conditional MCO, and now the Recovery Movement Control Order. It has been even longer for our colleagues at the Ministry of Health and the public healthcare system who have been on their feet responding to the COVID-19 epidemic back in late December before it was even named COVID-19. We are just beginning to see, however, the indirect effects of the COVID-19 crisis on cancer care. And we heard and know of that during the MCO, many patients faced trouble with referrals and rescheduling of their treatments and surgeries. We're very fortunate that for today's webinar, we have two great speakers who will be able to discuss with us some of the issues linked to the topic of our discussion. We have with us Prof. Nur Aishah Taib, who is a consultant breast surgeon at the Universiti Malaya Medical Centre. She is a director, or the director, as it were, of the Universiti Malaya Cancer Research Institute and a driving force behind Malaysia's successful bid into the City Cancer Challenge. She is also a member of the Cancer Care Working Group. Our second speaker is Dr. Feisul Idzwan Mustapha, who is a public health physician, best known for his leadership in prevention and control of non-communicable diseases in Malaysia. His work includes policy and program development and strategic implementation of interventions for the prevention and control of NCDs. His most recent work is the development of the National Strategic Plan for Non-Communicable Diseases 2016 to 2025. Welcome to you both.
Thank you, Azrul, for the invitation.
And thank you, Azrul, for the kind introduction.
Okay. Yeah. So for today's webinar, we're going to kick off with a 5-minute opening statement on where you both think we are on cancer treatment today in Malaysia, and then we'll proceed to our discussion. For our participants here joining us today in the webinar, please do send your questions via the chat channel, and we will try to get your questions answered by our panelists. So let's start, shall we? The floor first goes to Prof. Nur Aishah. Please go ahead.
Okay, I think to start off the discussion today, I think we are all interested in the same thing. We want to see definite improvements in cancer care in Malaysia. So we know there are several drivers of, what is really happening right now is a lot of our patients are presenting at late stages, even before the COVID-19 epidemic. So we have to figure out how to improve to get people to come earlier, even in the environment of COVID-19. And of course, quality care. We have, actually in Malaysia, we're very lucky. We have a whole spectrum of basic care right up to maximal care in cancer care. And we have to thank our very vibrant private sector, as well as our Ministry of Health hospitals that provide free treatments to the very poor patients in Malaysia. Okay, but given all these strengths that we know we have limitations, because I think Azrul will put out later some data from our National Cancer Registry showing our poor outcomes, late presentation. So given that we are now in another environment, even though we are not doing so well, given with another environment like this, how do we use the opportunities that has been given to us? Because I think we can see the strengthening of Ministry of Health in an environment where we are forced to work together. So I think I'll stop there. Azrul.
Thank you, Prof. Aishah. And I hand it over to you, Dr. Feisul.
Right. Thank you, Azrul. I think just to add on to what Prof. Aishah has mentioned, in terms of the burden of disease for the country, NCDs, non-communicable diseases, contributes the largest. Over 3/4 of Malaysians would die from NCD, and cancer comes second after cardiovascular diseases in terms of cause of death. However, if you look at the trends for some developed countries, cancer has exceeded cardiovascular disease in terms of, especially in terms of premature mortality. So we are heading in that same direction as well in terms of the burden of disease. One of the issues we face is late presentation, and I would like to go back to that later on as well. The data from the what Professor mentioned about the Malaysia National Cancer Registry report, the latest one is the 2012-2016, shows that about 1 in 2 of breast cancer patients, for example, present at stage 3, stage 4, and you're talking about now, in view of the availability and accessibility of screening and primary care treatment, and yet 1 in 2 are presenting late. Where are we in terms of comparing with other countries? I would like, and of course the people who already work with cancer would know, but this is for the benefit of people who are not working in cancer. We do report the comparison between Malaysia and the other countries in the registry report as well, which refers to the, which compares looking at data from the cancer incidence in 5 continents. And you will see where Malaysia sits for overall cancer and for other types of cancers as well. You would see, if you refer to that report, that in terms of incidence, we seem to be sitting on the lower part of the incidence compared to other countries, which leads to several experts in cancer feeling that this is underreporting on our part. We are not capturing cancer patients, but that's more of a technical discussion. I'm not sure whether we want to go there later on. So in terms of burden, it is high. In terms of incidence compared to other countries, we are not so high. But I think there's a lot of things that we should be concerned about. I'll stop there first. Thank you, Azrul.
So I think maybe adding on to what Dr. Feisul mentioned about the comparison, maybe just to start up the scenario on what's happening in Malaysia. This is up to 2016 data. You can see breast cancer is the commonest cancer. So we can use it as a good indicator of where we are now with cancer care in Malaysia. So you can see that the 5-year relative survival rate in Malaysia, if you compare to Singapore, to Korea, to Japan, we are very far behind. And I think the mention of late stage presentation is one of the drivers of this, what we see here. But there is also other factors that we should look at in terms of access to treatments. Okay, so I think we'll stop there. Okay, Azrul, back to you.
Thank you, Prof. Aishah. We have been very anxious as to the period of the MCO and the CMCO, and there's been a lot of discussion online, offline, in the media, amongst clinicians, oncologists themselves, and especially, I think, even in Putrajaya, as to whether or not the treatment of NCDs, and in this case cancer, were affected during this period of which we had a lot of restrictions concerning movement, and hospitals were forced to prioritize in terms of their procedures, and there were a lot of referrals going on. But, you know, we like to look at these things in the form of a challenge, but also possible opportunities. So if I were to ask both of you, and I'll start with you first, Prof. Aishah, what kind of challenges and opportunities in cancer treatment did you see emerge during the MCO and CMCO?
I think the main challenge was that there was definitely a slowdown or a shutdown in the public health hospital services with regards to diagnostic care as well as cancer treatments. So, for example, I think the first 2 weeks of the shutdown, the MCO, I think main hospitals like HKL actually had shut down clinic visits and so on. In PPUM, we also struggled. What happened in the first few weeks was we were all transitioning towards a more controlled clinic environment. So we had to sort of space out the patient on regular routine follow-ups. But we still actually had an open system to seeing patients with new symptoms. Okay, however, that information was very difficult for anyone to actually communicate with the public because everybody was scrambling for an SOP. And I think most hospitals at the earlier part of the MCO were actually struggling to manage what was safe in the hospital. So I think we have to take that in consideration because the good thing about the opportunity here is that I think we've gone through that, you know. We have actually gone through a period where we had to act quickly. Of course, there were a lot of limitations. I think the hospital management, I think they didn't sleep, I think 24/7 week that time, trying to figure out how to make it safe for everybody. So the shutdown, you know, for example, we had routine elective cancer surgeries planned for the next like 2 months, okay? And for breast cancer, we had like 30 patients waiting for cancer surgery. So then it came on to the innovation. So what happened in that period of time? I think it was very good that we actually have our professional networks. So we have like College of Surgeons, we have a breast chapter, we have communication with the other surgeons in the other sectors, other universities, other health, Ministry of Health facilities, as well as private sector. So we did do a lot of negotiating with our colleagues, and I think everybody wanted to work together. So what happened was a lot of our patients were shifted on to hospital UIA at that point. So, and those who could have insurance and so on were advised to go to private hospitals. So I think I have to, you know, raise my hands to those our colleagues in the hospital who actually had to do the logistics. I think our surgeons, medical officers were calling up patients, organizing, trying to get them through the system despite all the limitations. But it just shows that I think if we organize ourselves better, the services are available. You see, in Malaysia, we have services available, both public, private, universities, and so on. But how do we use all these resources in a way that we can improve access to all Malaysians? So I think it had a semblance of trying to solve things, but of course, obviously it's not easy. So one of the other things I think what Ministry of Health was trying to do was to work with private hospitals, and they actually managed to have CSR funds for patients. Actually, I think there was some communication. I'm not sure, maybe I shouldn't disclose these things because these were all people with true, you know, they really wanted to help, very good intentions. They want to really make sure the services does not stop during that time. But I think the mechanisms are not very clear yet. How do we work between public, private, and if private, they're providing CSR, who are the patients who are, you know, who can receive this?
Let's get to those topics in a bit, but you definitely pointed out quite a number of opportunities, and despite the challenges that were faced due to the restrictions imposed. And it sounds like, you know, we started off rocky and then it became much better after a while. And certainly we started to see communications flowing between the different specialists, the different organizations, but most importantly, the different individuals working together to fill in gaps. And this helped tremendously, I think, from the national picture. And certainly, I think the Kementerian Kesihatan Malaysia and Ministry of Health would have been able to see this over there in Putrajaya. Dr. Feisul, in your opinion, what did you see happen due to this crisis situation that improved on the delivery of cancer treatment in the country?
Okay, I think I'll make three key points here. Firstly, pre-COVID. Let's talk about pre-COVID. Cool. For cancer, in terms of delivery of care, our health systems is already struggling. Full stop, right? We are already struggling. Come COVID, I think COVID-19 itself shows that government and society can get together for a common goal. All right. In terms of that condition itself, it shows that even within the health sector, we can work together. It shows that civil society individuals can play key important roles. And more importantly, I think one of the key lessons from COVID-19, when they talk about prevention of COVID-19, it sits outside of the health sector, in the hands of other key agencies and ministries and in individuals. And I think that learning is very important for NCD and in cancer itself when it comes to prevention. Because, you know, pusing balik, people keep asking, what is ministry doing? What is ministry doing? If they kept asking that for COVID-19, there's nothing much that ministry could do to prevent COVID-19. And it is the same for cancer. So that's my overall second point. My third point will be to add on to what Aishah have mentioned about the ability for us to try to do our best to cater for the disruption of services for cancer. Unfortunately, we don't have the data yet for how much disruption it has caused. I am working with colleagues, and just to highlight one which I'm fully aware of is with Dr. Sri Ganesh from UPM, who's running a study in almost all MOH hospitals, trying to quantify the degree of the disruption of delivery of cancer care throughout the MCO period. So then we will have our own data. And there are several other studies looking at, for example, disruption to the screening services that we're running for diabetes. So, okay, better late than never, we're doing it. But already there are many information available from other countries. For example, I just like to highlight, WHO did a survey for all member states looking at disruption of services, particularly in NCD services. In countries, many countries are reporting disruption. But I just like to highlight one thing which stood out. Rehabilitation was the most disrupted when it comes to cancer. Oh no, sorry, not cancer, NCD. Because people think that rehabilitation is non-essential. So that was the most disrupted component when you talk about the whole continuum of cancer care. So I'll stop there first.
At the same time, it does sound, though, Doctor, that these are lessons learned that we can actually see from the stress tests that COVID-19 put onto the public health system to see where we are able to see which areas are strong and which are needing further improvement, but also where those are vulnerable to potential future outbreaks or the need to impose such restrictions of movement and limitations of liberty. Now, Malaysia is not unique. Many of the other countries are facing similar situations, and some countries have, in fact, arguably collapsed in terms of their public healthcare system. And Malaysia, alhamdulillah, you know, things have been relatively well in the sense that we were able to cope with the number of cases, but also in terms of the delivery of essential health services. It has been disrupted, but we were able to cope. But I want to, at this point, bring in a question from one of the participants of today's webinar. It comes from Professor Norlia, who is a breast surgeon at UKMMC. she points out that there was very limited radiotherapy facilities for women in the East Coast, especially in the public health setting. And they were starting to see women there with T1 and T2 breast cancers undergoing unnecessary mastectomy rather than breast conserving surgery to avoid the hassle of having to come to HKL for their radiotherapy. So we have a situation where because of this need to address what is arguably an access issue where they would have to come to KL instead of having that option available on the East Coast, is there a way for us to address the capacity gaps that continue to exist in the, Kelantan and Terengganu, despite us knowing that there are gaps? If you look at a mapping of hospitals that provide cancer treatment, in Malaysia, the East Coast is really very, very small in number, whereas the West Coast, it's concentrated there. So is there anything in the government's plans for the next 5 years to look at addressing this East Coast gap?
All right, I'll try to answer that first. I think the question is, what are we doing about this, right? We do know cancer is an increasing problem in Malaysia, and what are we going to do about this? My first question is, who is this we? Is we the government? Is we the MOH? Is we civil society? And I'm sure there are many members of civil society joining us today because they are very interested. Are we communities and families and individuals? You know why I say this? Because this we, everybody has an important role to play. That's my first point. Second point, second point, because this is not an easy question to answer, is about prioritization of limited resources. I always, you do know, well, all of us Malaysians in this room would know that we spend very little in terms of GDP on health. We need to spend more. That's definite, not just for cancer, for other NCDs, and there are many other health conditions which plague us Malaysians. Right now, because COVID-19 is a very loud epidemic, it's loud. They're getting a lot of money, right? But the money is coming from somewhere, so some things have to go, right? It's not like a limitless, bottomless pit. Cancer or NCD is a very silent epidemic. Senyap. Doesn't excite people, doesn't make suddenly government want to spend another 100 million ringgit on cancer. So there is that role for us to play when we say we, to make this a bit more loud, to champion. That's where I welcome involvement of civil society, trying to raise the awareness, it's not simply for me a matter of awareness and knowledge. We have the data, right, to show that cancer is increasing burden, and Prof. Aishah can share, and of course, like Prof. Nolia as well, will have plenty of data to show that the burden is increasing. But the thing is, when it comes to policy making, policy decisions, people don't just use data, right? We have to accept the fact that when it comes to policy making, it is also about politics, and it is also about the data, and it is also about public perception. What is the public move for this agenda? I'm sorry, I am circumventing the question, but without the political will, it is very difficult. And those people with the political will not be joining this kind of webinars, unfortunately. So I'm talking to a converted audience here, and I'd rather not talk about politics. Politics is something I can't do much about. It's a very interesting topic, but it is intertwined. And well, we all know what the current politics of Malaysia right now. So I'll stop there first.
Well, let me talk to you on the point of data, right? And arguably, yes, there's been a lot of situations where decisions are being made, even though the data points in one direction, the decision points towards another direction. And one of the things that's been a priority for not only the government of Malaysia, but also Malaysian healthcare, both in the private and public sector, and also the different NGOs working on the topic, is to improve on how we understand how cancer is experienced here in this country. And we want to be able to improve on that data picture, as it were, and as you rightly pointed out. So 2 weeks ago, the Ministry of Health announced and issued a circular requiring for cancer cases to be reported online. And this means that it needs to be reported as opposed to it being voluntarily reported as it was the case previously. So could you tell us what is the significance of this decision and how does this help improve on how we understand cancer in the country?
Okay. Sorry, Professor nak jawab dulu ke?
Jawab dulu ke?
No, let Dr. Feisul first. Dr. Feisul first. And then you can respond.
Sebab I dengar suara dia dulu. From the epidemiology point of view, I was trained in epidemiology. Data is key. Without data, it's very difficult to make decisions, to make recommendations. That's the epidemiology in me. The policy making person in me knows that data doesn't move people, not the right kind of data. And this is where I envy people who work in the private sector, especially those lobbyists. And I'm talking about not just NCD, lobbyists in other sector. They are very skillful in tugging heartstrings, appealing to your emotions, changing your priorities. What are your priorities? And sometimes priority is not the data that is, which is valuable to us. An employer might not care about the increasing burden of disease, but will care about the amount of money they're spending in terms of catering for their employees, and their healthcare benefits. If I can propose anything that will reduce their costs, they'll be interested. So that's just one very simple example about advocacy, not talking about what is the data shows, but tweaking the data in terms of making it a priority. I think changing behavior is not easy at the individual level, while you're talking about now changing behavior at the organizational level. So going back, yes, data is important, but however, we have to make sure that our patients are, you're talking about now cancer diagnosis, right? Our Malaysians are screened. Malaysians are aware of early symptoms so that they seek treatment, so that we detect them early. So that's the first step. And then whether we can help assist them stay within the system in a way like a patient navigation, so that they can get optimal care throughout the full continuum and not lose them. And then they come back again at stage 3, stage 4. I think that's one of the key things which is happening in Malaysia. Despite the availability and accessibility of treatment, we lose them, I would say, in the center where we could detect them early. We lose them, then they come back late. That's a separate discussion altogether, because that goes into the social, cultural, religious aspect of Malaysians, why, and also our knowledge.
So let's have Prof. Aishah respond.
Yep.
Prof.
Okay, I think back to the question on the online reporting of the cancer registry, right? So there was a circular that was sent to, I think, the director of hospitals to ensure that when they are reporting new cancer cases, it's reported using the online portal that's provided by Ministry of Health. I think we have to separate the issues into two, actually. One is the reporting itself, and the other is the mechanism of reporting. So I think what the Ministry of Health has done, I think the last 2 years or so, was to pilot the online system. So I think I've been very blessed in a way, because when we were engaging about the Cancer City Challenge, we sort of engaged a lot with Jabatan Kesihatan Negeri Selangor. And I would say there has been a lot of effort to do roadshows to teach all the public and private hospitals about the mechanism of reporting. So that means there is an online mechanism of reporting, but traditionally our registry was a manual system. So hospitals voluntarily reported cancers using manual papers, and I think the paper was like in triplicate. So like one copy will be left in the hospital, one will be in JKNS, the other one goes to cancer registry in IKN. But, you know, manual systems, and then we are Malaysia, you know, baru in a sense that all our internet banking is done by internet. Everything can be done by digital forms. So I think Ministry of Health was right in having the vision to improve the mechanism of reporting. But the reporting itself is still voluntary. So if you ask even my hospital, we don't report everything, because in the past, manually, only interested groups would report. So maybe the breast cancer group would report. But when we did a survey among the different disciplines within one hospital, some disciplines were not reporting because they never knew there was such a thing. So I think the mechanism of reporting is one thing, but the actual reporting is the other. So I think all hospitals, it has to be, the solution for this is not just providing a platform. The solution is really to get people to report. And how do we do that? One, voluntary. Maybe you can really get hospitals interested to voluntarily report all their cases. I mean, we're trying to do that in our hospital, but is individual hospitals going to be motivated enough to do that? We don't know. But if you make it a mandatory reporting, so for example, immediate reporting would be TB, dengue. It's mandatory. You have to report. If not, you are liable in the legal sense. Can we do that for cancer? Because, I mean, of course, TB, dengue, you see immediate deaths. But cancer, the deaths is going to be 5 years or even 2 years later. Can we make it mandatory? I think we've been trying to advocate for this to Ministry of Health. And I know the process is going to be really difficult because you got to go to Parliament, make it an act and blah, blah, blah. But is it worth it? Probably.
So you're arguing for a legislative approach towards the notification of cancer cases. So you put it into the law. I know Dr. Feisul is not a lawmaker. I'm not asking him to be a lawmaker, but let me ask very quickly, is it hard to include cancer as part of one of the notifiable diseases in the legislation?
It's not unique. Singapore does have a legislation making it compulsory for notification. However, there isn't a place for us to park it within the existing act. So you would need a new act. So Prof. Aishah mentioned about the notification of infectious diseases is because there is the very now famous, everybody's familiar with Act 342.
I think everybody is an expert on Act 342 at this point.
342 already. So there isn't an act for non-communicable diseases. It's something that we have mulled over in terms of legislation. But again, just to sidetrack, there are behaviors that I like to legislate when it comes to unhealthy behavior, you know, nutrition, diet. So I would rather focus that my efforts on making sure Malaysians are more, well, at least our children are less exposed to marketing of unhealthy food, for example. We don't legislate that. It is a code of conduct right now, self-regulated. There are many aspects. It's okay. I'm digressing. Yes, it is something that is worthwhile doing, but we will need a new act.
Well, let's go to the issue of the National Cancer Registry. The latest edition was just launched earlier this year, and it covers the period of 2012-2016. We've been talking about data, the need for us to understand more of where we are in cancer, which makes for a better argument in terms of improving on campaigns, awareness, interventions, and treatment of cancer. So what we know from this registry is that it recorded almost 30% increase in the number of recorded deaths within the period compared to the previous cancer registry data. And 70% of cancer cases are being detected, as you mentioned just now, in the late stage, either third or fourth stage. So the question here is, are campaigns for people to be screened and detected earlier not succeeding? What can we do better to improve on this? Dr. Feisul.
Oh, that's a very loaded question. Wow.
The
answer is no, right? You are terrible. Okay, so we talk about cancer prevention. Let's talk about, you can think about it as primary, secondary, and tertiary prevention, right? So primary prevention, for example, immunization, we're pretty good at that. When it comes to hepatitis B, we are hitting 99% coverage. When it comes to HPV, we are 82+%. And both the HPV, we're running it as a school-based program, and I'm concerned that it'll get disrupted this year because, well, our students are not going to school, right? You're not immunize siapa kat sekolah, but we're asking parents to take them to the clinics. But anyway, so you have that. Then you have the issue about changing behavior. I've mentioned earlier, Malaysians don't care lah. That's why they still try to lintas sempadan. Kalau tak ada polis, we have, despite the advisories and very clear risk, people still go against advisories, and let alone, and that's immediate, COVID-19 is immediate, whereas for NCDs, it's many years up ahead. All right, so going back to primary, our NHMS 2019, National Health and Mobility Survey 2019 showed that about 1 in 3 of Malaysian adults have low health literacy, inadequate health literacy. Okay, health literacy is not just about awareness and knowledge, it's about how you digest and how you practice what you have learned. So when it comes to lifestyle, there is much to be desired. So that's primary prevention. When it comes to secondary prevention, screening, we have the opportunistic screening right now for breast, cervical, oral, colorectal, and we also have the high-risk screening, right, for prostate, NPC, lung, liver, right? Screening is still low, right? For the colorectal cancer screening, we are reaching even less than 1% of eligible population. 1% no, less. Okay, sikit sangat. NHMS 2019 has also showed that 3 in 4 women aged 40 years and above never had a mammogram. Okay, 1 in 2 women aged 18 years and above do not practice breast self-examination, and 60% of women aged 20 years and above did not undergo pap smear in the past 3 years. And the survey also asked questions about whether they are aware about HPV self-sampling. Only 1 in 4 of women are aware. All right, NHMS just shows you where we are. What's the situation? It doesn't tell you why that is. We need to really understand why this is happening. Is it just lack of awareness or knowledge? Or is it we lose them in the translation of, knowing?
Let's pose that question to Prof. Aishah. Prof.
Okay, I think many years ago, I did a very small study, but it was a qualitative study trying to understand why women present with advanced cancer. Okay, so maybe I can just quickly get to this slide. Can you see it? Nampak kan?
Belum lagi.
Belum lagi.
You're not sharing that one.
Share.
Okay. Right. Okay.
Okay. So trying to understand why people come late. So, sorry, I'm trying to move my slides. Okay, so it is quite complex lah. I think the problem with us is that when things become complex, we sort of quickly just try to run away from it. But it is complex. It's a complex issue. There are many things that we need to do. So I think one of the you can see the gray boxes. These are probably the most important things that we need to focus on. Breast health literacy. Okay, people are not aware about the disease and the outcome of disease. People are not aware of treatment and its outcomes. And then it's just not the community, it's also the primary healthcare providers. So we need to target this. And as what Azro mentioned, what are we doing enough? I think if you ask the NGOs, they are working tirelessly, I think, to do this. But unfortunately, we're not very coordinated. If only we could be a little bit more coordinated, we could get better coverage. We might be harping on the same population, the people who actually attend this sort of community campaigns. But how about the people at home, the people who have no access to information on internet and on handphones and so forth? So I think we need to understand how we can reach this type of populations, how best to reach them. So I think there are some research that we're trying to go into, like I think what we're trying to do in UM is we're looking at urban B40 group of people, and now I think given the COVID, we have a lot of challenges in doing these studies, but yes, we still will go into the communities to understand how they communicate health information among themselves and how they get this information. I think without knowing that, we won't know how to reach the people who don't get the information. As for GPs, primary primary care physicians, they play a major role actually in cancer, because they are the ones who are going to educate people about screening, finding new early symptoms of cancer. So we have to be a bit more coordinated in providing this type of education to them. They might have to have some incentives that they are considered, completed some education about cancer to actually provide this type of services to the community. Okay, so breast health literacy, very poor right now, but we need new solutions to actually get this done. Okay, then of course finances is a major problem. Coping is another problem. Do you know that in Malaysia, how many psychologists are there really in the public sector? Really, there are very few psychologists, there are very few psycho-oncologists. So I think I saw in the chat box, there was some question about how we managing capacity in terms of human resource capacity. So at the moment, I think the COVID-19 just showed us how we can work together. We need to separate services and the financing of healthcare. Services may be available in different pockets. It could be in public sector, private sector, but we must find ways to finance this. So you know how many psychologists there are in private practice? Probably most of them are having practices in the private sector because they have no career pathways in the public sector. But how do we use this resource? So I know there are some startup companies trying to see how they can provide psychological services to cancer patients, but we need a roadmap. And I think this is where leadership is very important. And I think Feisul is trying very hard to sort of help to coordinate. So I know there are a lot of task force being formed in the Ministry of Health where they actually include people from different sectors. But, I think we need a roadmap for Malaysia. And this roadmap, unfortunately, is a complex roadmap. We probably need to prioritize late stage presentation as the main thing that we should solve within the next 5 years. So if we can have that roadmap, I think everybody will know what to do. NGOs are forever asking where can we do to help. So if we have leadership, I think we can organize ourselves better. So I think it's important that we try very hard to in the next year or so, because we have mechanisms. WHO has good ways of roadmaps that we can use. For example, NCCP, the National Cancer Control Policy document, that is an important document where if we can make sure, sudah hilang.
Prof. Aishah, actually, I totally agree with you on the issue of needing roadmaps, and certainly the leadership makes a difference in terms of how we want to get there. Now, I know on our webinar today, there's a lot of cancer, people living with cancer, people who are on treatment today, who have been on treatment for years with what we have available in our treatment arsenal. And the question I would want to ask is, if we wanted to see an improvement or change in the way we treat cancer in Malaysia, where would we start? Dr. Feisul started off his statement just now comparing Malaysia to a few countries. And definitely there are some areas where we see there being more options available in those countries compared to Malaysia, but Malaysia also has more options compared to other countries like Indonesia, for example. So if you wanted to start on the improvement of treatment in cancer, we don't want the next 5 years to still be where we are today. We want it to be better, right? So where would you start if we wanted to improve on the quality and access of treatment?
I think we need a roadmap. That roadmap is complex. And we have to prioritize late stage. So late stage means you got to sort out the health literacy issues, the navigation issues, access, financing and access is another major thing that we have to sort out at a higher level, because there are a lot of things that we are not doing properly because we are not working together. So for example, maybe by reducing the prices of drugs through procurements, things like that may help. tremendously, not just for people in the public sector, but for the private sector. Because services are there. You have the doctors. I mean, of course, they're not enough. But if you look at the division of labor, private and public, there's so few oncologists, so few cancer surgeons in the public sector. So we need to figure out the financing part. Services, I think we just have to bring everybody to the fold. We have to work as a whole thing rather than public service, private service. So I would say we need a roadmap and strong leadership to actually get this off the ground.
Dr. Feisul, a roadmap. I think you have a roadmap already with regards to cancer. You were one of the architects for the NCD strategic plan, but you also have the cancer control plan, which is up for renewal, I think this year or the following year. So obviously this is something that you in Ministry of Health and Putrajaya have thought about. Or what do you think about what Prof. Aishah's comments concerning a roadmap to improving treatment cancer in Malaysia?
Thank you for Prof. Aishah for highlighting about the NSPCCP, National Strategic Plan for Cancer Control Program. I fully agree. You need strong leadership for any agenda, especially a more difficult agenda, and you need a roadmap. And you need a good roadmap. One of the key issues I feel with roadmaps sometimes is it tries to cater for everybody's needs. Trying to make everybody happy. We are in a resource constraint setting. Prioritization is there. And how very much I like to prioritize based on data. I also have to prioritize on what's feasible and what's acceptable. And that's
financially and politically.
Yeah, and that's very subjective, right? I can ask for the moon and the stars, but if there's no money for the moon and the stars, I mean, then what's the point of talking about it? So anyway, prioritization is key. I see a bunch of very difficult questions on the chat box. Thank you very much. These are very valid questions for us to consider. Most of it I can't answer. However, I'm committed to use this as part of the input for NSPCCP. And if you agree, Azrul, maybe myself and Aishah, we can consult our other colleagues who may be able to respond to these questions. We compile them into a Q&A. And then for you, because you do have the registration, right? Details, I hope, for some of them that have registered as participants, we could or make it available on your website as a Q&A. I think these are, I appreciate the people coming in to listen to us talk on a Saturday morning. I think it's only fair for us to try to respond as best as we can to our capacity to respond to these various questions. So going back, yes, the NSPCCP is work in progress. One of the key learnings we had and one of the key comments we had, we did not engage enough people. So we will try to address that. By engaging doesn't mean that I will make everybody happy. No, you just engage. Some people will be upset with me for not doing enough for certain types of cancer or certain aspects of care. I'm not out to make everybody happy. I'm trying to do the best with what resources I have and what's feasible to move forward. And I'm a public health practitioner. I'm very biased in terms of what I think is important. Obviously, compared to the practicing oncologists, they have their priorities, or people who work in rehab and in palliative care. I fully respect. But then again, I'm driven by the fact that if we can prevent them early or prevent the late stage, then we can prevent most of the more expensive and more resource intensive care of of cancer. It applies for all NCDs. But the advantage of you guys in cancer, you have a very strong civil society. Diabetes, hardly any. Cardiovascular disease, hardly any. Heart failure, you do know heart failure has a higher mortality prognosis than most cancers. There isn't any civil society. There isn't a strong civil society. So you have something to work against. Maybe we can go back to talking about the role of civil society as well, but I'll stop there first.
Well, and then the other thing is like investment in people and in monitoring and evaluation. I think these are the things that we somehow have put as low priorities, you know. So I think, Feisul, I think Ministry of Health is trying hard. As you say, we now know that we can work together. But given that cancer is such an important disease requiring such complex type of issues to be solved, maybe we should invest in more people in, let's say, cancer registry. Because I know the people in cancer registry, even the cancer unit in the Ministry of Health is very minimal. I don't think you can manage with such small staff, and then and you need more specialists in those departments. So I'm not sure whether you want us to advocate for that, because I think we can do so much better if you're better staffed. Because I think we don't see this, you know. I honestly feel that a lot of people are saying, oh, Ministry of Health not doing enough and all that. But what is really happening is that they are under tremendous constraints. Their staff movements are so quick, like their turnover. You don't have like people who are going to be there for years to develop things, you know. So we need to change that way too, because I think the human resource that you put into these departments will help to maneuver, you know, what's happening in the next 5 years. Because given that biasalah, you know, it's happened to all public departments. You have a staff, that staff naik pangkat, they move on to a different section. So you don't actually get good people who know what they're doing for the long term.
Professor, I wanted to just bring up the issue here, because we talk about gaps, we talk about resource gaps. Dr. Feisul emphasized how resource strapped we are, especially in these tough times. And one of the key buzzwords that came out for over the past, I would say even 10 years, has been the issue of public-private partnerships. To be able to look at healthcare in Malaysia, not as silos, here's public, here's private, but actually looking towards working together to try to address some of those issues that we're talking about. Because right now, sometimes we look as if the government wants to do everything, but obviously you can't, because you don't have an unlimited budget. Private sector feels that we can only pay for this much, we can't do this much, somebody has to pay, and the issue is about financial resources there. So why can't we emphasize more or build more on building trust and relationships to help reduce that financial burden? But also, when we talk about things like the patient assistance programs, which are supposed to help with the government providing essential treatment for cancer patients, then it suddenly is stopped. You know, it's not there anymore, because maybe there's a gap in trust there, or issues relating to that public-private partnership. So I think the way forward really, and I say this to both of you, is really working together, right? I mean,
working together with what do you call that, best practices? So that
best
means
practices.
Yeah, best practices. That means how do we make this type of relationships, you know, trust? That means, you know, like a lot of times private sector is looked upon as a money making, you know, like a money making thing. And public hospitals supposed to manage everything and give everything for the poor, blah, blah. But really, this trust relationship is all about best practices. How do we know that we're doing the right thing? I mean, like, you know, when we buy, like, say, a government tender, it's always, there's so many steps to it, right? The policies that's there, you know, people say, oh, we cannot do it because the policy says is that. But you know what? In order to achieve something, you might have to adjust. And adjustments can be done with best practices. I mean, I'm no expert in all these things, but we could get lawyers involved. We could get, people from, to make sure that what we're doing is ethical, is transparent. So this challenge is, I think, what is stopping us, you know, because there's so many distrusts. And the distrust is because we are always thinking the other is out to get maximal benefit. But how do we work together? Because macam, you know, like, let's say procurement. How do we get hospital in the private side to provide cheaper drugs? I mean, everybody say, oh, then private hospitals say, oh, you're going to undercut us. But, you know, why not just have a chat first and see the governance. I'm no expert in this really, and that's the other thing I wanted to bring up actually. Sorry, Azrul. We don't have enough health system experts, kat Malaysia.
Yeah.
We have a health system school in Malaysia. Ada ke, Feisul?
Do we?
Do we? So
I think Universiti Malaya has one, right? No.
We have people who are specialized in this field, but there are very few of them. I mean, we can ask Murali how many people in Malaysia are experts in health system management. I don't know. Feisul, you should know.
No. I agree with you.
Dr. Feisul, go ahead.
It's a rare species.
Yeah, very rare.
What I'm interested, and I'm just looking at the chat, is and this point that I've made is about understanding behavior, behavioral scientists, sociologists, anthropologists. We really need to understand behaviors of Malaysians so that we can address it better. Right now, we work on the premise that people are not aware, people do not know. That means just raising awareness and knowledge. But my challenge to you guys out there, it is beyond that. It is, what is their priority? Is it aligned to their social, cultural, religious values or not? If you do not address all these factors, and it's not the same for all Malaysians, jangan lupa kan, men versus women, socio-economic class, level of education, religion, this all interlinks. Again, using the word Prof. Aishah guna tadi lah, it is complicated, and as experts, we are expert in that lah, making simple things complicated. Itu tak ada apa lah.
But we can make complicated things simple.
So Dr. Feisul, and Prof. Aishah, we have the 12th Malaysian Plan that's coming out. Well, as long as when it finally gets finalised and dibentangkan, probably next year. We are looking towards improving cancer treatment and care, the management, the prevention of cancer in Malaysia for the next 5 years. I mean, what kind of recommendations would you make that would help increase the prevention of cancer and provide for people who are living with cancer? For the 12th Malaysian Plan, what's your vision for the next 5 years?
For my perspective,
of course,
I mentioned about the primary prevention. Okay. So the vaccination
primary
component,
care.
I mean primary prevention. So the vaccination component that has to be strengthened and ensure it is sustainable. We have anti-vaxxers nowadays. That agenda can easily get side rail. And if we, for example, look at cervical cancer, if we can maintain a high immunization rate for HPV, and if we can then incorporate good screening, there is a preventable cancer in the future, maybe 10 years, 15 years down the line, maybe 20 years, that you see minimum cases. So that's one. The other thing, we need to address the low health literacy, all right, among Malaysians. And I have no easy answer for that. I need my colleagues who work with health behavior. We do have sociologists or anthropologists in Malaysia, but usually they don't work in health. They work in other fields, politics, religion, but not so much health. So because then we can be more specific and more targeted in our raising awareness and knowledge efforts and more personalized. However, I'm not saying the treatment is not important. You cannot strengthen one thing and not the other, because it is a whole continuum, right? So I'm not going to say palliative care rehab is not important. It is, I'm getting old. I'll probably be a recipient of that service some years, and I would like to be able right now in a position to make that change, so that when I need it, it's there. But you're asking me from my perspective, and that will be my focus in terms of the primary. And the secondary, strengthening the screening. Self-screening is the way forward. And then again, you need to empower people to want to do it. And as technology evolves, I'm sure there are other screenings that will become self-administered and will be more affordable, more accessible. Again, it needs investment right now. It's not about the potential savings in the future. That's the usual argument. Dr. Feisul, you can save 1 billion ringgit in the next 10, 15 years, but you need to invest 200 million now.
Yeah, today.
Government don't have 200 million. You know, what are you talking about for me to save 1 billion or whatever billion in the future? That's the reality when it talks about health economics. Oh, that's another, not so many species out there as well. The health economics pun tak ramai. So you have your health system tak ramai, behavior scientist tak ramai, your economics, health economics expert pun tak berapa ramai. Bukan tak ada. Kan, these few individuals, everybody wants them, penat lah. So that would be my
Okay.
focus for the primary and secondary. Last stop.
Professor.
All right. So I think given the complexities and the difficulties that we know about, the 12 Malaysia Plan, if they can invest in good digitization of data and collection of data for monitoring and evaluation. So we want to have real-time access to this data. So I mean, if we can do something like Sri Lanka, we can do things like, you know, we have a lot of potential, but I think we're not garnering on the experts who know about this. So for example, I'm going to be critical about, let's say, Ministry of Health EMR systems. How can we use third-party systems that are different for different hospitals? So in the end, you cannot talk to each other, you know, the system doesn't talk to each other. So before implementing any major, I mean, a lot of investment is in e-health, electronic medical records and all this, but have they actually talked to experts, people who know what works, what doesn't? There have been a lot of failures over the last 10, 20 years. We must learn from them. We cannot repeat what we have done before. So I think investment in data collection, registry, all this require new technologies, and I think we have the expertise. We need to get them in the fold. We cannot just do it for the sake of, okay, we're going to do EMRs in all hospital, and then you find all the hospitals cannot talk to each other, and the cancer registry cannot get data automatically from them. It has still got to be a manual process. It shouldn't be. We should be investing in innovation technologies to improve the data monitoring and evaluation of cancer staging and all that. Okay. The second one is,
yeah, go ahead.
Okay, satu. Number dua, I think the people. We don't have enough experts, health system expert, health economics. Is there a way to, you know, in 12 Malaysia Plan, I know 12 Malaysia Plan ni selalu hardware je kan? Is there software involved? If there's software involved, of course, then we should have building capacities for cancer care with projections. Already we know how many people will be having cancer, how many radiotherapy machines you need to be put in Sabah Sarawak, East Coast, you know. I think, I'm not sure, but this is what we have, a complex issue. We need to pay attention to it. You need to invest a task force or something. But the key message is multi-sectoral. You cannot solve this problem with just doctors. You cannot solve this problem with just NGOs. You need financing experts. You need all kinds of experts, legal and everything. So itulah, I think we need leadership.
I think the key theme here that's been running from Dr. Feisul and yourself has been the issue of investment. The need to invest in people, in resources, in treatment. We even have somebody on the chat who's suggesting that we should invest in best buys for treatment, which includes targeted therapies, which have the highest survival differences. We're looking at investing in not just oncologists, but also other specialties of which cancer depends on, radiologists, you talked about health systems and so forth. So just looking at this chat group, you know, you can see already there's a lot of a diversity of issues that we've only just begun to touch on rather than go into in depth. But we come to the end of today's webinar on looking at cancer treatment in Malaysia for the next 5 years. And we are just, I'm not even sure whether it's the tip of the iceberg. I think it's just one snowflake on top of the entire iceberg that we've spoken on today. So somebody has suggested, and I'm floating it to both of you, asking, can we have a part 2 of this webinar on another weekend? So because I've got you on the spot right now on live, I would like to know whether you're open to having another session, part 2 of this same topic on another weekend. What do you think?
I'm good.
Oh, okay.
maybe we can look at what the chat, and perhaps we can come to have decision in terms of what would be an interesting scope.
Okay.
There's a lot of questions about the actual treatment. I wouldn't be the best person to talk about that in specifics, for example.
Okay.
So you know, so if the viewers would like something more focused on treatment, and perhaps we can find a different panelist. So I'm not refusing, but it's just that I'm you know, so
we'll
it's
prioritize the theme.
Prioritize so that
see,
something that I can contribute a bit more productive and more you know, something which is I'm more an expert in. So but yeah, no problem.
So we have Prof. Aishah, you're good for that? Yeah, so there you have it, through democratic process of putting our two speakers on the spot on a live webinar. We have come to a decision that we will have a part 2 of this webinar looking at the state of cancer care and treatment in Malaysia for the next half decade. So with that being of a decision point for today, I would like to thank you both Dr. Aishah and Dr. Feisul for taking the time out of your Saturday morning to being great guests this morning. Go ahead.
In Norlia's comment that we need to invite a politician into the webinar.
No!
So you can decide either Tun Mahathir, Anwar Ibrahim, or PM.
The PM. No, we should have the PM. I think we should have the PM here. You know, it'd be good. Then we can have a speedy decision on the issue of investment. So, to all of our participants, thank you for being such a great discussion, for putting out your points. I'm sorry that we couldn't go through all of your questions, but as mentioned, we will definitely park these questions for a future second part of this webinar that we're having this morning, and we will inform you through our Facebook page and YouTube channel. So to all of you who have not already done so, please join the Cancer Care Working Group Facebook page and join the YouTube channel to see the recording of this session as well as previous webinars. So that's it for today. This is Azrul Khalib signing off and wishing you a great weekend ahead. Assalamualaikum warahmatullahi wabarakatuh and goodbye.